Good evening, everyone. My name is Justin Guan. I'm the co-president of the RFS Communications Committee. I'd like to welcome everyone to tonight's informative webinar on innovations in IR, brought to you by the SIR-RFS Women in IR Committee. So the person who is helping to coordinate this, or the first person, is Peyton Kramer. So I'll go ahead and let her start talking here soon. But before we start, I'd like to remind everyone that this session is recorded and will be made available on YouTube at a later time. If you have any questions during the webinar, you can go ahead and type them into the questions box or save them until the end and we will address them. So without further ado, here is Peyton Kramer from Women in IR Committee.
All right. Hey guys, my name's Peyton Kramer. I'm the medical student leader of the Women in IR Committee. First of all, I just wanted to thank you so much for joining us this evening to hear about the latest and greatest innovations in IR from Dr. David Prologo. Dr. Prologo is an assistant professor at Emory University and is nationally recognized expert in ablative therapies and has pioneered several new procedures in the subspecialty. His research is focused on the application of image-guided techniques to deliver stem cells, treat cancer pain, and manage obesity, for which he was recently featured on the Today Show. Tonight, myself and two other medical students, Jess Clark and Gail Stanton, will be discussing these topics, and then after we do the three presentations, then the floor is kind of turned over to Dr. Prologo, and he can answer any questions that you have, and add any additional comments that he may have. So throughout the presentations, please hold off. Well, actually, you can type your questions in that little question box on the right on GoToWebinar, but we're not going to have any answering or any discussions until after the three sessions. So with that, I guess we should get started. So I'm going to first talk about obesity, and then Jess Clark is going to present, and then Gail Stanton. So let's get started with the obesity lecture. So, obesity defined by having a BMI greater than 30. This is a global epidemic affecting more than 600 million people. It's the leading contributor to mortality, morbidity, disability, and healthcare utilization and costs in the United States. The traditional approach to obesity has been pretty straightforward, create a net energy deficit by doing a low-calorie diet or modifying behaviors, exercise, even medications, but really none of these work. So the only thing that's been shown to really work is bariatric surgery. And among those candidates for bariatric surgery, only 1% of patients are actually getting that procedure done. It's a big open procedure with a lot of risk and potential for complications, and it's just not being done. So something else needs to be done. So what is another option for these people? Well, it was thought that why is bariatric surgery so successful? Is it because, mechanically, yes, you're restricting the stomach volume, but another concept that really is, got people thinking is maybe it's because you're also excluding the fundus of the stomach. This is the region where that potent appetite stimulant that we all know, ghrelin, is produced. And by eliminating the ghrelin production, then maybe that's why this procedure is so effective. So what else can be done? Based off of that concept, that's where bariatric embolization kind of arose. So by embolizing your left gastric artery, then now you've completely altered the endocrine function of the gastric fundus, and now you're no longer having that ghrelin production, which is your hunger hormone, as I previously mentioned. So it's thought that maybe these hormones and this metabolic aspect of appetite regulation is more important than just the restricted size of the stomach. So just a general time frame. So back in 2007, a group first noticed that embolization is going to modify the hormones, specifically ghrelin. In 2012, a canine model showed that this embolization could reduce your sub-Q fat In 2013, a porcine model showed that the embolization reduced ghrelin and weight gain. In 2015, another porcine model showed that smaller embolic beads had more of an effect on reducing ghrelin levels as opposed to larger beads, more on the scale of like 500 to 700 micrometers. So, but up until this point, there weren't really good human trials. So in 2015 was the first prospective report of bariatric embolization as a weight loss therapy in obese humans. However, this was consisted of 5 patients and a letter to the editor, and the endpoints weren't super clear. There weren't really rigorous inclusion and exclusion criteria. So there are non-specific methods for collecting and measuring some of their data. So because of this, more studies need to be done. So back in 2017, just a year ago, this paper came out by Clifford Weiss's group up at Hopkins, and this is the preliminary results of the BEAT obesity trial, and this is the paper that I'm going to be discussing. So BEAT obesity, standing for bariatric embolization of the arteries for the treatment of obesity. And the purpose of this study was really just to clarify the endpoints and develop a more scientifically robust study. So to perform a pilot prospective clinical trial evaluating the feasibility, safety, and short-term efficacy of bariatric embolization in patients with severe obesity. So the primary endpoint of the study was clinical safety. We're very, very early on in this studying how bariatric embolization is used in humans. So safety was the first priority, defined by 30-day adverse events. And the secondary endpoints, there were several. Importantly, they were looking at the efficacy of the procedure defined by % excess weight loss. They looked at all of the hormones that are associated with obesity, such as ghrelin and PYY and leptin and a couple others. And they did questionnaires assessing quality of life. They looked at hunger and satiety and looking at appetite throughout this post-op period. So inclusion criteria for their study. So you have to be able to give consent. BMI between 40 and 60, have to be nearby, and have vascular anatomy that's amenable to the procedure defined by a 3D CTA. You have to be have adequate hematologic, hepatic, and renal function as listed below, and be over the age of 18. And then exclusion criteria, I'm not going to go through all this, but if you've had prior some of these abdominal surgeries, prior radiation, severe liver disease, and with portal venous hypertension, notably the active H. pylori infection, so no ulcers at the time, and no major comorbidities. What else was important to highlight through here? No, clearly no contraindications to iodine or any contrast issues. So yeah, here, very clear defined criteria. And then after that, they enrolled 5 patients who were eligible candidates for the study. So you can see the demographics of these 5 patients. So average age was 36.8. Their average BMI was 43.8, and mean excess weight was 143 pounds. Important to note is that 4 of these patients were females, and obviously a very small sample size. So once these patients were enrolled, they obtained several, values at baseline. So they got consent and then just a general H&P. The SF-36 questionnaire, it's just a general health survey assessing those things listed up in the left: vitality, physical functioning, etc. They did the 3D CTA, as I said, to assess the vascular anatomy, perfusing the stomach, basic lab workup, including H. pylori, a hemocold blood test, a meal tolerance test, which is looking at baseline hormone levels before and after a high-calorie meal. So they were looking at ghrelin, GLP-1, PYY, leptin. Demographics, the IWQOL questionnaire is the impact of weight on quality of life questionnaire, very similar to the SF-36. And then the hunger questionnaire was just using a visual analog scale ranging from not hungry at all to extremely hungry. They would ask, how hungry are you right now? And they would ask that before meals, and then after dinner, and then how hungry have you been generally in the past 3 days was asked before breakfast each day. They did gastric emptying studies to assess motility, and an endoscopy to look for any ulcerations or gastritis, glucose tolerance test, and pregnancy test. So after that extensive baseline workup, then the patients underwent the procedure under moderate sedation. They selected the celiac artery through femoral artery access, and they performed a DSA and cone beam CT to assess the stomach perfusion. They used a microcatheter to select the arteries of interest. So whatever was perfusing the stomach, the fundus of the stomach, whether that was the left gastric, the LGA, or the gastroepiploic, the GEA. So in some cases, we'll see that one artery needed to be embolized and others both were embolized. And then once they had selected or identified their arteries of interest, then they gave nitroglycerin, verapamil, and heparin to promote distal penetration of the embolic particles. And then they used a microcatheter to actually embolize the fundal arteries using 300 to 500 embospheres, micrometer embospheres, until stasis or decreased blood flow. And then an anti-reflux device was used if it was needed. So everyone likes pictures, and I think this is a good demonstration of, when you're going in and looking at the fundus, how you decide how many vessels you need to occlude. So this picture on the left is showing, this is a pre-procedure image, and it's showing that the left gastric artery is perfusing, most of the fundus, but you have this wedge-shaped defect that obviously is being supplied by some sort of collateral or other vessel in the area. So then on the right, you can see after the embolization of the left gastric, you've lost that perfusion to that region of the stomach. And then once you access the gastroepiploic artery on the left, you can now see filling of that previous wedge defect. And then on the right is after embolization of the GEA, and you no longer have it. So in this case, in this patient, they needed to do both, but you can see in both of the right images, here's one, here's the other, the distal perfusion has been occluded. So technical aspects of the procedures for the 5 patients in this study, in patient 3, 4, and 5, they needed to embolize both. It shows you how much volume of embosphere was needed, and fluoroscopy time, how much radiation was given, how much contrast, and the procedure times. And important to note that all 5 of these were 100% technically successful, defined by complete occlusion of the vessels supplying the fundus. So after the procedure, here's just a kind of timeline of the follow-up. So at each appointment, you can see that they did the H&P, and then they have the quality of life QOL questionnaires, the food logs, the hunger scale, and then fasting blood test, and the basic lab workup, etc. And then At 2 weeks and 3 months, they got an endoscopy, and then at 1 month and 6 months, they did gastric emptying studies to assess motility. So the results from this, the 30-day safety profile, which was our primary endpoint. So importantly, there were no major adverse events, and adverse events were defined by the Society of Bariatric Surgery, and here are what they, this laundry list of major adverse events listed here, and none of those occurred from this procedure. There were 2 minor adverse events, transient pancreatitis that completely self-resolved, and the patient was discharged home with symptomatic management after 48 hours. And also the second minor adverse event was a superficial ulcer that was seen on endoscopy, but by the 3-month endoscopy that had also resolved. Some other minor complications: 3 patients felt nauseous, had some vomiting, epigastric pain, and then 1 patient had mild gastritis that was seen on endoscopy. So overall, I think the safety profile, was up to par with what could have possibly gone wrong and what they were expecting. So here's a table showing, all the results. So you can see this first column is showing you their baseline score, and then changes up to 3 months. I think the most important results from this table to highlight are the ones I've boxed on the right. So you can see the weight loss by month 3 was 9 pounds, and then also the ghrelin scores, which is the appetite stimulant hormone, had decreased by 17.5 after 3 months. Also listed in this chart are, some of the other scores that we had discussed and their lab values, etc. So if we look at the hunger and appetite scores over time, you can see that all were decreased so we're looking at, up to 12 weeks afterwards. All patients had decreased scores except for the mid-afternoon score was higher than baseline. It peaks at 2 weeks and starts to rise, but none of the others actually increase above baseline over time. And then the SF-36, this was that original quality of life questionnaire. You can see that all of these factors improved over time too at the 3-month follow-up, and this supports the other quality of life assessment, which also showed the same results with the general increasing trend over the 12 weeks. So conclusions from this paper: bariatric embolization using the 300 to 500 micrometer size beads was really well tolerated in these severely obese patients. There weren't any major adverse events or significant short or intermediate term toxicities. The gastric artery fundal embolization didn't result in substantial ulceration, nor did it have any impact on motility. The procedure improved quality of life as evidenced by those questionnaire results. Weight loss was achieved despite general noncompliance with the recommended weight management program, and as I previously highlighted, there was the 9% at 3 months, and patients reported an average decrease in subjective hunger in the immediate post-bariatric embolization period, with a gradual increase in appetite over the ensuing months, but never back to baseline, and I think that's the important part. So limitations of this study: it was designed as an acute safety and toxicity trial. So you have a really small sample size with only a 3-month follow-up period. There wasn't a control cohort, but you have to start somewhere, and so this makes it difficult to make any long-term conclusions. And what can patients receive another procedure of bariatric embolization? Who knows? It's hard to say at this point to make any long-term conclusions or study concepts like that. Another limitation, the embolic beads used in this study were 10 times larger than the preclinical study beads. So here we used 300 to 500, which was larger, but this was per FDA recommendations because there was concern that the really small beads might cause gastric ulcers. And actually just this month, this paper on the right came out, and they were looking at how size did affect ghrelin expression and weight in a pig model, and they actually showed that the smaller beads were more effective in reducing ghrelin levels, but also the smaller beads were associated with higher risk of gastric ulcers. So that was interesting, and I think kind of contributes and adds to this idea that, you know, you might need the small size to get that, really see those effects in hormone levels and get that distal embolization, but at the same time it comes at the risk and adverse event of having increased ulceration risk. And then a third limitation, this study cohort was really non-compliant with their diet and exercise plan. So in the future, you know, improving ways to increase compliance, but at the same time, you're studying this in a patient population that probably isn't going to be compliant to begin with, so it might be more reflective of real life, was just my take on it. But additionally, for research purposes and to see how this procedure actually pans out, then certainly need to improve compliance. And then also in the study, 4 of the 5 candidates were female and predominantly African American, and studies have shown that race really does play an effect on how they respond to bariatric surgery and how easy or more difficult it is to gain, lose weight, etc. by race. So that could also have you know, might change your data a little bit. So next phase of the trial, they're expanding the investigation to a multi-institutional study of 20 patients to reveal the long-term safety and efficacy and its potential mechanism of action. So I think, you know, there's a lot going on and the future is very promising, but until we have, you know, more numbers and more studies, then it's hard to say what the future of this procedure looks like. But right now we have some great results and I think it looks very promising. So here are all the references, and that is all I have for y'all. Okay. So, Jess, are you with us?
Yeah,
So,
can you hear me?
Peyton,
Yes.
that was a great presentation. Thank you. Is the plan to run through all these before we say anything about these?
So you can make a quick comment. We were going to hold
Okay.
off till the end for a full discussion.
Okay, no problem, no problem. That sounds great. That was a very good presentation. Thank you.
Well, thank you. Okay. All right, Jess, this floor is yours.
Oh, I lost it. Just give me one moment. Let's see. All right, bear with me, folks.
All good.
There we go. All right, good evening, everyone. Thank you for joining us, and thank you to the other presenters, Dr. Prologo, and of course, Women in IR as well. So my name is Jess Clark. I'm a third-year medical student at A.T. Still University, and tonight I will be presenting Dr. Prologo and his colleagues' study on percutaneous image-guided delivery for the transplantation of mesenchymal stem cells in the setting of degenerated intervertebral disc disease. All right, and so here's kind of just a brief outline of what I'll be covering tonight. I'm just going to provide a very brief review of what degenerative intervertebral disc disease is, the rationale behind the study, an overview of the study design, We'll move into study methodology, the results, the author's discussion, and then the conclusion. So with that, let's begin. Degenerative intervertebral disc disease. So, of course, as I would imagine everybody knows, the intervertebral disc sits in between two vertebrae. It's composed of the outer annulus fibrosus, inner jelly-like substance of the nucleus pulposus, and its job is to absorb shock forces that are transmitted through our mobile spinal column, through standing, positional changes, anything that goes through the spinal column is going to be transmitted through these discs to help absorb that shock. And if we look just posterior to that, of course, we have the spinal cord, and then the nerves shoot out laterally. And if we can imagine, when these discs degenerate, then there's going to be less space and going in between the vertebra. And so it can definitely cause irritation to those nerves. And of course, if it's a bone-on-bone structure, that will cause pain as well. And injury and aging, it can lead to degeneration, either or a combination of both. And this also makes it more susceptible to disc herniation, which can, of course, then irritate the nerve too. So we would expect pain in the affected area throughout the spinal column. You know, it can be in the cervical, thoracic, lumbar region. For the purpose of this study, we'll be focusing on low back pain. But if the nerve is irritated, it can lead to a radiculopathy. So that can be radiating pain in whatever distribution of the nerve, as well as numbness, paresthesias, and weakness. So what does the management of chronic low back pain look like? And so I've listed it kind of in order of increasing steps, if you will. There's oral pharmacologic treatment, so that can be, you know, your standard NSAIDs, possibly opioids, which is a whole nother discussion, and also something like gabapentin, which can help with neuropathy or radiculopathy symptoms. Exercise therapy, so this can be PT, physical therapy, it can be Pilates, aerobic exercises, manual therapies such as manipulation, massage. I was even reading about acupuncture in the use of chronic low back pain. And then getting to more invasive procedures, there's the epidural steroid or non-steroid injections. And then for degenerative disc disease in specific, the place for surgical intervention seems to be pretty limited. It doesn't seem like there is a whole lot of reassurance that if you get this surgery that it will be beneficial in the setting of degenerative disc disease, but there are the options of spinal fusion surgery as well as disc replacement surgery. And so as you can see going through these, a lot of it is focused on either immobilizing or just trying to minimize the progression of the symptoms, which we will get into more in depth later on the paradigm shift there. So what's the impact of degenerative disc disease? For the patient, of course, they're going to be in pain, and this can start out as an acute pain and then progress to a chronic pain. And many patients that have chronic low back pain, it's a pretty significant and profound effect that can lead to many days missed at work or decreased functionality and you know, disturbance in sleep cycle, and it becomes this ripple effect where that can lead to many feelings of frustration or just these negative feelings that are secondary to their chronic pain, as well as increased costs for the patient. So going to see the doctor for more visits, or rather imaging, or different types of treatment, it's going to be possibly financially burdensome to the patient. Looking on a more national scale, Dr. Prologo and his colleagues' article referenced the number $500 billion per year, the United States, from lost wages, medical payments, insurance burden, and also disability benefits were listed as well. So that's, I mean, that's a pretty big number for chronic low back pain or degenerative disc disease by itself. So this caused for a paradigm shift moving from, okay, right now we're focused on immobilizing or decreasing the progression, but what about actually restoring and repleting and building up? And this is where interventional stem cell therapy comes into play. And so several studies have successfully demonstrated in vivo transplantation of mesenchymal stem cells to intervertebral discs through surgical techniques, resulting in the repletion of degenerated intervertebral discs. So there are a number of animal models where this has been proven successful, and then 2 significant trials in humans. So the first is Yoshikawa et al. And this was done in 2 human subjects. There was bone marrow fluid aspirated from the iliac crests. It went through a series of processes, and the solution was incubated with a collagen sponge, and then that collagen sponge was surgically placed back into the human subject. And in this study, they were followed for 2 years, both radiologically and clinically, and both subjects showed improvement, both radiologically and clinically, and there were no untoward or adverse effects. And moving on to Orozco et al., this study followed a very similar procedure or technique. However, it was done in 10 human subjects, or a very similar harvesting method, to Yoshikawa's, but it was done in 10 subjects, and they were followed for 1 year, both radiologically and clinically. And again, all 10 subjects showed improvement, both radiologically and clinically, over that 1 year period without any untoward effects. So that was the efficacy. Those 2 studies showed that it could be efficacious if we transplant these mesenchymal stem cells into humans. But Dr. Prologo and his colleagues' study addresses the technical barrier that was encountered during mesenchymal stem cell transplantation. This study asked the question, okay, it's efficacious, but can it be done through a non-surgical, a clinical delivery, something that's less invasive? And we're going to go over the results here. But first, we're going to touch on the study design. So this is a preclinical trial that was using a xenogenic model. There were 4 female pigs weighing between 28 to 35 kilograms apiece. Approximately 100,000 radiolabeled mesenchymal stem cells were delivered, and it was delivered under fluoroscopic guidance through percutaneous needle delivery of these stem cells. And we're going to, again, touch on the timeline and all of that, but the delivery and the containment of these stem cells were validated both through CT and PET scans at various time intervals, as well as histologic validation through immunohistochemical staining for the human sequence. And we'll touch on the importance of that. Let's get back to there. There we go. Okay, so how was the study done? First, the intervertebral discs had to undergo degeneration. And so after proper anesthesia for this, we're going to be focusing on the image over here on the left. A 16 gauge coaxial needle was advanced to the annulus, we're looking right here, of the intervertebral disc between L2 and L4. L2, L3, and L4, L5 under fluoroscopic guidance, and then an 18 gauge biopsy needle was advanced through the coaxial anchor, and the tip of it was placed in the middle of the intervertebral disc. Once this needle position was confirmed, then a core needle biopsy specimen was obtained. And again, this is the induction phase. And so 10 days later, for this one, we're going to be focusing on the image on the right. 10 days later was the transplantation phase. So the same fluoroscopic guidance technique was implemented. However, the needle size was different. So we have a 22 gauge outer needle coaxial system to the outer annulus, and then a 25 gauge discography advanced to the center of the degenerated intervertebral disc of L2, L3. So again, approximately 100,000 radiolabeled mesenchymal stem cells were delivered to the intervertebral disc, and the volume of injectant at each disc was 1 centimeter cubed. And so this is a down the barrel view that we're looking at here. And what's important to note is within each model, it was injected into this L2, L3, and then the remaining levels within that same model acted as controls. And there was refinement of the technique, which is important to address. But first, so this top row was the CT and static PET imaging that was obtained immediately after transplantation. And then this bottom row is 3 days later. So up here we can see that there was accurate delivery to the site of action. And then this 3 days later, it confirms that the mesenchymal stem cells have stayed within that site of action and haven't dispersed. So one thing that Dr. Prologo and his team realized from the first trial was the first image was not confirmatory. It didn't confirm that the stem cells had been placed in the desired spot. And then repeat imaging 4 days later actually showed dispersal of the cells outside of the site of interest. And so it really spoke to the importance of technique and technique accuracy and delivery in retaining these stem cells where you want them to act. And so their technique was refined, and in the next 3 models, that's what we're seeing here, is that their stem cells were not only accurately delivered, but were retained within that same region. And 15 days after transplantation, that's when the histologic data was obtained. So the pigs were euthanized, and then the intervertebral discs were surgically removed. We can see a gross image here. This arrow points to the outer annulus fibrosis, and this is the inner nucleus fibrosis. And there was immunohistochemical staining for the human sequence, which we're seeing here. It was positive in the disc transplanted with human mesenchymal stem cells and negative in the control discs, which is over here. And this is important because the transplanted cells, they have to be distinguished from any mesenchymal stem cells that could have been recruited to the site. And so this specific immunohistochemical stain really helped to distinguish and make that difference. And that's the marker that helped with that. And then these results were correlated with the CT and PET results to have one big final image. So this is pulled from the article, The Author's Discussion and Interpretation. Strengths, of course, this is a minimally invasive technique. IR is known for the minimally invasive techniques and having decreased morbidity and shorter recovery times. But also, it achieved its primary purpose in demonstrating that there can be successful and accurate, precise transplantation of human mesenchymal stem cells through minimally invasive measures, percutaneous delivery, which is pretty remarkable. It also demonstrated the importance of utilizing imaging throughout to document and track outcomes to ensure that these mesenchymal stem cells are being delivered and retained within their site of action. Limitations that have been seen not only in this study but also in previous animal studies. It doesn't replicate the erect walking pattern of humans, so there may be different pressure strains demonstrated in this erect walking pattern versus the horizontal pattern, and so that could possibly affect the results. This next bullet point isn't so much a limitation, but rather it just speaks to the aim of the study. This is addressing a new delivery technique versus the efficacy that was described in the other studies that I previously discussed. So bottom line from this article is that the percutaneous image-guided delivery of these mesenchymal stem cells into the intervertebral disc space is really a promising minimally invasive technique that could help reduce patient morbidity and cost, and further investigation in human trials is warranted. So how might this study change clinical practice? Again, big picture, we're shifting our thoughts away from immobilizing and moving toward restoration, generating these new cells and producing that extracellular matrix, these growth factors that mesenchymal stem cells provide and allow for. Interventional radiology is known for its innovative, minimally invasive procedures, and the prospect of combining these techniques with the precise placement of these mesenchymal stem cells, it could really theoretically apply to other organ systems or other areas of the body, osteoarticular issues. And the use of a non-invasive procedure to restore structure is really an exciting prospect. If we're thinking of this patient population who may have already been out of work for a very long time or already frustrated with their pain and how it's really impacted their life, these non-invasive and or minimally invasive procedures can be associated with decreased recovery time and possibly get these patients back out and doing the things that they would like to be doing possibly. And the refined technique described in this study could certainly change the landscape of clinical practice in chronic low back pain and beyond. So this was truly a remarkable study, and I'm definitely very excited to see where it goes in the future. I think it definitely has a place in clinical practice, and I can't wait to see what the future holds. And that is all I have. Here are my references. Thank you.
Alrighty, can everyone hear me?
I can hear you.
All right. Let me go to the beginning of the presentation. That would help. There we go. All right, hi everyone. My name is Gail. I'm going to be talking about the use of cryoablation in the treatment of phantom limb pain and amputees. I'm the last person to go, and I know you all have been listening to us for a while, so I'll try to be brief. But I'm really excited about this topic, so hopefully I can do it justice. So to start off with some definitions, phantom limb pain is described by UpToDate as a complex, poorly understood pain syndrome, and there's no clear consensus on the mechanism, and there's currently no standard treatment. The pain is variably described as burning, crushing, electric, or aching. It's very common. It occurs in greater than 50% of amputees. There's no strong evidence that supports one specific treatment. There are pharmacologic treatments that include gabapentin, memantine, or ketamine. There's also non-pharmacologic treatments that might include virtual reality or mirror therapy. And I want to differentiate this from residual limb pain because it's going to come up later in the presentation, which is also known as stump pain, that's pain of the amputated limb itself. This is a chronic pain that can be reported by up to 95% of patients. And persistent pain or persistent residual limb pain can also indicate ischemia, neuroma formation, pressure points in your amputated limb, or infection. So why cryoablation? Like I said before, the mechanism of phantom limb pain is unknown. And one of the questions that hasn't been answered yet is this a peripheral or a central process? One of the things we know is that in amputated limbs, we see biochemical and anatomical changes both peripherally as well as centrally. There are two previous studies that use cryoablation to treat phantom limb pain with success. These are smaller studies with 5 patients and 10 patients. And our cryoablation in this study is very similar to what they did. We used a 17-gauge cryoablation needle, and we did 2 10-minute freeze cycles alternating with 2 5-minute passive thaw cycles. And the mechanism that's thought to be behind this is that we get these ice crystals that form and cause endoneural edema that leads to Wallerian degeneration of our nerves. However, because we maintain our other structures in our nerves, such as the perineurium and the epineurium, these nerves are able to regenerate, but in a more functional manner, and that is how we treat the nerve pain. So in this study, we recruited 24 patients. They were recruited based on a previous history of an upper or lower extremity amputation. They were required to obviously have phantom limb pain, and they also were required to be refractory to other treatment modalities that I discussed earlier. Based on the distribution of their symptoms, we identified a target nerve, And if they had a neuroma along that target nerve, that was specifically targeted. They were first treated with a bupivacaine or betamethasone nerve block. And then 24 hours after that block, they were asked if they had a response in their pain. And based on that, 3 patients were excluded because they did not respond to that nerve block. And the remaining 21 patients went on to actually undergo cryoablation. Following cryoablation, these patients had their functional status assessed. They had a baseline assessment and then a follow-up assessment at 7 days and 45 days. Their pain was also assessed, again at baseline, 7 days, 45 days. And for pain, we also performed a long-term follow-up. Pain was assessed using the visual analog scale that I'll review in just a minute, as well as, and their functional status was assessed using a modified Roland-Morris disability questionnaire. Additionally, at this long-term follow-up visit, patients were also asked if they would undergo cryoablation again. And then based on this, 4 patients actually volunteered to have a second ablation. So they went back, had another ablation, and again had the same follow-ups. So based on this, I thought this was a nice representative figure that kind of followed a patient through this process. This patient, these are images from a 54-year-old patient who presented with upper extremity lightning-like phantom limb pain. In figure A, you can see here, this is an MRI that was actually taken 2 years prior to his cryoablation. And you can see here indicated by these white arrows, that's actually a brachial plexus neuroma that was targeted. In panel B, this is from his bupivacaine betamethasone nerve block. You can see here, indicated by white again, is his neuroma. And these circles down here indicated by the black arrows, that's the brachial plexus. Down here in C, this is from his cryoablation placement. Cryoablation needles, they were placed either using ultrasound or CT guidance. This patient went with ultrasound guidance. So again, you can see his neuroma and the white arrows are indicating the cryoablation needle. And then our final panel here, D, is during his cryoablation. You can see the 2 cryoablation needles, those white things in the center. And then each patient during their cryoablation, they had an image taken 8 minutes into that first 10-minute free cycle to confirm that our target nerve or our neuroma of interest is completely encapsulated within our ablation zone. So as far as our outcomes, we measured a number of different things. The first thing we were interested in, is this feasible or safe as a treatment for phantom limb pain? So for that, we looked at the technical success of ablation. And for safety, we looked at any adverse events that occurred. And I don't have a specific slide just on that later, so I wanted to mention that we did have 100% technical success. And there were no serious adverse events that occurred due to our cryoablation. As far as other adverse events, there were 6 patients who reported procedure-related pain that was controlled with anti-inflammatories. Pain was assessed using the visual analog scale that you can see here. At each assessment, the patients were asked to mark where they were on that scale. And functional status was assessed using the modified Roland-Morris disability questionnaire that you can see here. This is a list of, these are yes/no questions, primarily related to their activities of daily living and other activities. So patient demographics, I don't want to spend a whole lot of time on this, but I did want to point out a couple things. One thing that I thought was interesting is that you can see we have a really wide range of patient ages spanning almost 60 years. Again, a really wide range of time that's passed since their amputation, almost 50 years. The majority of patients did have a neuroma that could be targeted. 60% or more than 60% had a neuroma. And the majority of patients were actually lower extremity amputations. 81% were a lower extremity amputation. The statistical analysis in this study was done with linear growth modeling. And I wanted to take a minute to talk about this before we get into the data from the study, just because this was a new statistical method for me and I wasn't sure how many other people would be familiar with it. So linear growth modeling, this is a non-traditional method of statistical analysis. And it's interesting because it allows us to assess change over time within a group. And this is different than some other more traditional methods, such as maybe ANOVA, that really focus on assessing differences in between different groups. So basically how it works is we collect data from all of our patients, and then we fit a model to that data, and that allows us to estimate mean pain scores and mean functional scores. To do this, we have to have longitudinal data that requires at least 3 waves of data. Each wave has to have a consistent type of outcome measurement, and we also need to include a metric for time in our model. The benefits of this technique are that it's very flexible. It allows us to include patients with missing data points. Our data does not have to be time structured. That means that our data points can vary in time from patient to patient. And it also allows us to assess a huge number of conditions and covariates. So in this study, we did meet the criteria to use this technique. For functional status, we had 3 different time points, our baseline 7-day and 45-day visits. And for pain assessment, we added a 4th time point, which is our long-term follow-up. We used the visual analog scale and the Roland Morris disability questionnaire throughout, and we included visit number as our time metric. So to get on to our results, you can see here in this table we have pain intensity and functional status, and at each visit we have a mean score. These are means that are estimated by the model that we fit to our data. So with our mean, each mean has a confidence interval. So to start looking at the pain intensity, you'll see when we go from our baseline score to day 7 after our cryoablation, we do see a small decrease in their average pain intensity, but it's not statistically significant. However, when we go from day 7 to day 45, we do see a significant decrease of 3.1, and that decrease at day 45, that's also statistically significant from their baseline. And then when we go to our long-term follow-up visit, although we don't see any further decrease from our day 45, it is statistically significant decrease from their baseline. So we see an overall decrease of 4.2 points from their baseline to their long-term follow-up in their pain intensity. When we look at their functional status, we see something similar. When we look at day 7 compared to their baseline, we see a small but non-significant decrease. But when we go out to day 45 compared to day 7, it's a 6.1 point decrease between those two. And then we have a total of 8-point decrease from their baseline. And I think that's all represented really nicely in the bottom graph. You can see a small decrease from baseline to day 7. Our most significant drop is from day 7 to day 45, with a kind of a maintenance in that decrease in our pain intensity at our long-term follow-up. So we also wanted to identify if there are any explanatory variables that could affect their pain scores or affect their response to cryoablation. So we then included a number of other variables for comorbid diseases or patient demographics, and made another model that you see here, and looked for any variables that could be predictors for their pain scores. And we found 3 things that actually were significant predictors for pain intensity. So what we found here is you can see that patients with residual limb pain actually had a lower pain intensity by 3 points. Patients who had an upper limb extremity amputation actually had higher pain by 1.1 points. I want to point out that we also found that 80% of our patients in this study had lower extremity amputations. And then finally, patients who did decide to undergo repeat ablation actually had a higher pain at baseline by 4.2 points. The other thing we did is we looked at the interaction between time and the presence of residual limb pain. And we found that patients who had residual limb pain actually saw a smaller decrease in their pain intensity in response to cryoablation. So compared to patients who did not have residual limb pain, we found that at day 45, patients with residual limb pain had a smaller decrease in their pain by 2.5 points. And at day 45, their decrease was smaller by 4.4 points. And interestingly, at their long-term follow-up, these patients actually had a pain intensity that was higher by 1.4 points. So these patients started with actually lower pain, but they had a decreased response to cryoablation, and because of that, they actually ended up with higher pain at their long-term follow-up. And as I said before, there were 4 patients who actually volunteered to undergo repeat ablation. So again, they went through that entire ablation in the follow-up visits again, and we again fit a model to all of that data to look at the effect of repeat ablation. One of the things we saw, we're looking at this model here, is that compared to their first procedure, the baseline pain for these patients beginning at the second procedure was actually 2 points less. So what that means is that their improvement in pain from the first procedure is continued on into the second procedure. So they had the sustained improvement following that first procedure. The other thing we looked at is their response to the second procedure, and we found there were no statistically significant differences in their change in pain intensity following the second procedure compared to the first procedure. As you can see here, all of those were non-significant. And interestingly, the patients who had residual limb pain, they actually had significantly lower pain intensity at the long-term follow-up for the second ablation compared to that first ablation. So although they started with less intense pain, they had a decreased response to that first ablation, they did have further response to the second ablation. And when we look at functional status following the second ablation, what we saw is there were no statistically significant differences seen between the first and the second ablation at any point in time. One of the things I want to point out here is when we're looking at this general model column, for all of those values, if you look at the confidence intervals, they're actually quite wide. So you see overlap between all of those confidence intervals at each visit, which means that they also did not show any statistically significant improvement in response to the second cryoablation. And I just want to put up, these are the response we saw in response to the first cryoablation. You can see here their confidence intervals much smaller, and that's what allowed us to have a response there. So there are lots of things we can take away from this study, but I want to just highlight what I thought were some of the most basic ones. And the first, I think, is that cryoablation is really a feasible intervention for phantom limb pain. There was 100% technical success, and there was 0 serious adverse events that were due to our technique. Secondly, there were statistically significant improvements in both pain intensity and functional status that were maintained out to our second procedure, which took place sometime down the road. And lastly, interestingly, the presence of residual limb pain predicts a decreased intensity at baseline, but also a decreased response to cryoablation. Just some strengths and limitations of this study. I think some of the strengths is I think growth modeling is really well suited for pilot studies. We were able to assess a pattern of change in our patients, as well as identify different growth predictors. Another strength is I think that the two-step study design allowed us to really evaluate the response of patients before we actually performed the procedure. However, we have to keep in mind there was a small sample size. The study didn't involve a control group. There was no randomization or blinding. And also the patients were reporting their own outcomes. So it's a bit subjective. And last, this study finished up with a discussion of the future work. So in the future, the goal is to do a parallel arm sham-controlled randomized clinical trial. This can have the same inclusion and exclusion criteria. And using this pilot study, there were a number of things, a number of variables that we estimated to allow a sample size calculation. So it was estimated or hypothesized that we would need a minimum 0.5 point difference in visual analog scale between 2 arms of our study. Based on our pilot study here, we assumed approximately 7.2% variance. And based on our attrition rate in this study, we estimated a 16.7% attrition rate. So as you can see here, that takes us down to the 72 sample size. So that would be 36 patients in each arm of a randomized trial. Be very similar to the trial, the way this study was designed. So it would involve recruitment and identification of a target nerve, again with a bupivacaine and betamethasone block, excluding patients who did not have a response. But then at this point, we would randomize our patients into either a cryoablation arm or a sham procedure arm. And then again, we'd perform the same functional and pain intensity follow-ups. So here are the resources that I cited directly in this presentation, and I think we're going to go ahead and move on to questions now.
Okay, Dr. Prologo, if you would, kind of open up the floor and just give us any insight into any of the topics that we've discussed, and then if any of our attendees have any questions, you can just type them in the questions box or speak up.
Okay. Those were great presentations. Thank you to all three of you. So what I want to say, the reason why we picked these articles, Peyton and I settled on these articles, is because we were going to go with the theme of innovating in IR. And so everyone did a great job of describing the details of the study, each of the studies, but there are bigger issues that I was hoping we could just touch on quickly as it relates to innovating in IR. So the first trial, the BAE trial, the big picture there, well, the big picture for all three of these really is that we're going to use our existing skill set in interventional radiology to solve either a long-standing problem or a new problem, right? And so that requires collaborations with our colleagues, but it also requires a lot of logistics that you have to think about ahead of time. And that's really the reason why I wanted to do these three papers in particular. So the first one, the BAE trial, this is a huge market, right? This is a long-standing problem that's not been solved. Billions of dollars spent each year on this problem. But what we need to use our existing skill set to address this problem is evidence. And in order to get evidence, we need an IDE. And so I think that's really the rate limiting step for BAE is acquiring an IDE, which is permission from the FDA to run a trial, right? And that's different than permission from the FDA to use something for clinical use or an on-label designation for a device. This is the FDA's permission and outline for a trial for a new application. And so because we use medical devices and we're reaching outside of what is traditional IR, we've got to understand how you get an IDE and how the trial is run. And so at the end of the BAE trial, the reviewers must have asked for an elaboration on the potential limitations of the trial. And so they mentioned sample size and so forth. But the reality of the situation here for those investigators is that they applied to the FDA. They filled out some 45-page application, and the FDA came back and said, this is what we need from you in order to allow you to run this trial, because of course the FDA governs the IRB, which governs human subject research. So the IDE is the important part of that first trial, the BAE trial. And those were the first 5 patients that the FDA wanted safety data on in order for that group to move forward. So I wanted to make that point and further say that the IDE and FDA approval to run a trial and then potentially eventual FDA on-label designation for a device are also to be separated from reimbursement, right? Even if we go down that road and we're successful and there's an FDA approval for a new indication, that's a different process than what has to follow for true dissemination, which is to assign some mechanism of reimbursement to a new procedure. And that's something that goes through the AMA and involves negotiating with insurance companies and assigning CPT codes. The other thing about that first trial, keeping in the vein of innovation, is that it's important to consider that someone had to pay for that. And so as we think about innovating, we can first talk about the FDA regulations like we did and then eventual reimbursement after we identify a new problem. And then we've got to consider who is going to pay for this. And it is important to understand that you have to have money to run a trial. And I think early on when you're acquiring pilot data like this, industry funding is a really good place to start, and society funds are another good place to start. And then that preliminary data allows you to apply for larger grants. Last point about the BAE trial. If we intend to reach beyond what is our traditional skill set into new spaces, there will be some degree of hostility. And that's just sort of the way it is, how we feel about the vascular surgeons doing our procedures, right? This is kind of that in reverse. And so the people who manage obesity or manage pain or traditionally manage the conditions that we hope to help with, there's some degree of hostility there. And so it's going to be important to be able to speak their language. And that's another thing that this group did so well. Because 2 pounds for a 300-pound person is different than 2 pounds for a 150-pound person, they educated themselves about what the accepted outcome variables were, like excess BMI, excess weight loss. And so for us, as we read that, it's important to notice that those were very deliberately chosen in order to give us credibility in a different space. And so I think those are the important points about the BAE trial. The stem cell trial is same theme, right? This is a huge market, billions of dollars being spent, and not a good solution even after all these years. This is another place where we can potentially use our skill set to solve big problems, to solve what's called the first pass effect when you peripherally administer stem cells and they get caught in the lungs, or to increase efficacy by increasing concentration using local delivery. But again, we're faced with real logistical issues, which is if we intend to take a biologic like a stem cell and do something different with it than is traditionally approved by the FDA, we'll have to ask them to run a trial. You fill out that same form, but this time it's called an IND, and they'll come back and tell you, this is what we need from you in order to run a human trial. In this case, they wanted animal proof that we could indeed deliver the cells using a needle. What was intuitive to us, of course we can do it. The FDA wanted to see in animal studies. And so that's the big picture reason for that study. It was designed specifically in response to the FDA's request for animal data demonstrating our ability to deliver the cells under image guidance percutaneously with a needle, and they're still there days later, which is why we had to do the histology. And so that was the real impetus behind that study design, as opposed to just sort of coming up with something and seeing how it goes. And then the last one, the phantom limb trial, again, not to be brutally repetitive, but here's a new syndrome, or I'm sorry, a long-standing syndrome, right? But a new application for us, and we might potentially, as interventional radiologists, be able to offer a new therapy by marrying cryoablation and image guidance. In this case, there was existing FDA approval for cryoanalgesia using cryoablation targeted at nerves, and so we didn't have to go through those regulatory hurdles in this case. And so the study was then designed not in response to the FDA or in anticipation of FDA questions, but instead, the next step here will be a larger grant to study this in a bigger population with randomization arms. And so we deliberately and specifically designed the study to provide solid preliminary data going forward. And the last thing I'll say about this study is that you also have to be able to speak the language here. So when you enter into the interventional pain management space, there are accepted outcomes, and you have to understand what is a significant change in VAS, for example, and what are the things that make a pain procedure worth doing or worth the risk. And in order to translate your findings into the bigger picture, you've got to be able to speak that language. So those are the big points that I was hoping we could make after discussing all the details of the specific abnormalities and specific procedures. But that's the larger theme of innovation. So I know that was kind of long, but thank you for bearing with me.
No, we greatly appreciate that. Real life tips that I think are, you're not going to get from reading the literature and whatnot. And it's good insight to see where we are in the process of these things and, what needs to be done to move forward. So super exciting. And I think it is really cool that you're emphasizing, we have all these skill sets. What can we do with it? Really, really cool. So if people have questions, I don't see anyone typing, but I know questions have to be there.
Actually, can I ask a question?
Please, please.
Dr. Prologo, you said like one of the good places to look for like that initial funding source is industry. Can you talk a little bit about just like kind of where you start or where you go first when you start that process?
Yeah, actually, I have a whole talk on that. I'll spare you that, but I was going to show the 1 or 2 slides because people always want to know that actually. But anyway, the short answer is, well, it's not going to be that short, but in the beginning, when I started doing research, I was operating under this assumption that only federal dollars were sort of the respected dollars, you know, and if you took any industry money, then you somehow introduced bias into what you were doing and so forth and so on. So I didn't do it. And then as years went by and I applied for larger grants, I realized that the absolute golden nugget that you need to get a big grant that will separate you out from other applicants is prelim data. So anytime you have an idea, even if you have discovered the cure for cancer and you're sure of it, when you go to apply for a grant, the very first question they ask is, how do you know this? What have you already done? And you end up in this vicious cycle where you say, well, I haven't done anything because I don't have a grant. And you're saying that I can't have a grant unless I do something. And then you're kind of stuck there, right? And so my advice to anyone who's starting out now is get money from wherever you can in the beginning to do 5 patients or to do 5 animals. And society grants, society pilot grants are a great source of potential dollars to get that prelim data. Industry is usually happy for multiple reasons to provide a small amount of money to get pilot data. So those first 5 patients or those first 5 animals that might seem like you're going to have to write in a limitations paragraph that it's a small sample size, you need those more than anything to parlay your idea into a bigger trial.
Awesome, thank you.
Thank you.
Sure.
I have a question. So generally, I was in a bunch of cryo cases today, actually. You know, it's I think it is a commonly used procedure, but how did you get into the nerve ablation world?
So there's a little bit of an echo on that. I guess I'm echoing now too. But Peyton, can you repeat that question for me?
Okay, wait, hold on. I think it's gone now, yes? No. Hold on, let me mute and then start over. Is it better now?
That is better.
Okay, good. So I was in some cryoablation cases earlier today, and I think that is pretty commonly done in the IR world, but how did you specifically get involved in the nerve aspect of cryoablation?
Oh, okay, I see. That's a great question. So when I was a fellow, we did a lot of pain, and at that time, the cryoablation for painful osseous metastatic disease was arriving on the market. And as I was trying to build that practice when I was a young attending, I would get requests to cryoablate nerves in patients who had masses in their lower extremity that were too large for cryoablation or radiation or surgery, short lifespan, no motor function. And so that was the question. And the answer really was, I'm not sure. We didn't know if we could cryoablate nerves. And then upon review of the literature, people have been cryoablating nerves for 50 years without image guidance. And it just kind of went by the wayside because of the complications associated with blind sticks. And from there, we said, geez, if this is something that is helpful in this setting, what other settings can we use image guidance to target a nerve and give people relief? And it just kind of went from there.
Yeah, that's fascinating. Anyone else? Oh.
It looks like we have
a couple. There are. Hey, okay, yeah, cool. Okay, Jackie, do you want to start off? Yeah, just, oh, sorry. Hey, Jackie. If you look at under the attendees tab, you can unmute yourself.
Oh, hello. I think I figured it out. Can you hear me?
I can hear you.
Oh, perfect. I guess I just noticed that one of the exclusion criteria for the obesity trial was excluding patients with obesity over 400 pounds. I wonder if that's just associated with like the fact that maybe those patients are have more comorbidities. I know that they seem to they seem to have been aiming for patients that are obese but not, you know, super ill in this particular study.
Well, you're probably right about that, but I don't know that that's the reason for the cutoff. The cutoff is probably, I think at that point it becomes a technical issue. It's difficult to penetrate a patient at a certain size, and you have to be able to see the arteries in your microcatheter and so forth. So I don't know for sure, but my best guess is that it becomes technically difficult above that BMI.
Okay. Just wondering.
That's a great
Good
question, Jackie. I was actually wondering the same thing, because you know there is I guess distance limitation to a needle and a catheter, etc.
Right, and visualization, right.
Yeah, it's a kind of an interesting patient population to try these minimally invasive procedures on.
Indeed.
Has there been any pushback? Does anyone have knowledge if there's been any pushback from the surgical world that, you know, usually does bypasses?
So that's a good question. So that's exactly the sort of harboring hostility that I was alluding to earlier. That the world itself isn't always a truly collaborative place, especially when you get out into private practice and this is how you're paying your bills. But in this particular disorder, there are seemingly an unlimited number of patients. So I don't think we have that problem here.
There's no true competition.
Well, it's not like there's a limited number of patients in this case because you know, a third of people in America is hundreds of millions of people. So
yes.
So they're not too worried about it at this point.
Okay.
Okay, and Eamon, did you have a question?
Yeah, hey, I had a quick question about the role of residents in conducting the research.
So I think it's critical for residents to get involved in research early to learn the kinds of things that I talked about earlier, right? So that way you don't get out and you're in your first and second year of your assistant professorship and learn these lessons then, right? So I think it's so important, and anybody who approaches me, I try to get them involved. Also, another thing about residents doing research is it really gives you something to talk about when you go to interview for your fellowship or your job. And it can set you apart if you can talk about the interesting work that you did at your institution.
Thank you. Follow-up question to that. What are the sort of things you look at residents to have, I guess, like in their backgrounds and previous experiences and trainings to help them be prepared for contributing to these types of projects?
Well, I don't want to give so many real world answers, but honestly, I think the answer to that is you want somebody who is resourceful and interested in the work because everyone is so busy, and you really want somebody who wants to do it and is resourceful and can get things done. I think that's so much more important than any objective training or background. The best residents that I work with are residents who come in, we decide on a task and a deadline, and then we meet the task on that deadline and we get our project done. And to me, those are the easiest people to work with and we get the most done.
Excellent. Thank you.
Hi, I have a question. If there's still time.
Sure, if the question's for me, sure.
Yeah, I was more interested in the stem cell project and the trajectory. I was wondering if it's been applied to humans at all.
So not in that way. So those were sorry, I'm trying to remember what we were going to do in humans. So we were going to do autologous transplantation in humans. So those were xenogenic transplants, right? Those were human cells into animals, only for purposes of proving the delivery so that we could get the IND, which we got. But you still need funding for that study, even if you get permission, right? And that study was designed as autologous transplantation. So it would have been a bone marrow aspiration and then a spin down and then a redelivery into the intervertebral discs. I ran out of time and haven't done anything with that for a while. But I think there's an entire interventional stem cell therapy niche to be had in interventional radiology. The bigger issue really is beyond the intervertebral discs and all of the applications for which human beings are getting peripheral administration of stem cells, because each time you give a peripheral dose of stem cells, if it's autologous or allogeneic, there's a first pass effect where 90+% of them get trapped in the lungs, and the rest of them sort of have to find their way to the site of action. And what I learned during the design of that trial is that there's a ton of work going on, both in industry and basic science, whereby people are trying to paint these cells with homing proteins to get them to the spleen or get them to the pancreas. And honestly, I think it's as simple for us as using a percutaneous delivery mechanism under image guidance to inject them into their site of action and bypass the first pass effect. So with the design of stem cells to treat diabetes and the need for them to reside in a pancreas, we can just inject them there. In graft versus host disease, the site of action is the spleen. We could either percutaneously inject them there or intraarterially deliver them there. If the embolic effect is not too bad. There's Crohn's disease, where they're using stem cells right now clinically by peripherally injecting them and hoping they make their way to the bowel. And so we could potentially deliver them intraarterially. So I ran out of time personally, but I think that there's a huge field just ready to be had for interventional stem cell therapists.
Very cool. And in terms of keeping with the vertebral disc treatments, would you see a role for pain management, like inserting local or extended release capsules near the nerve to act as like a longer acting nerve block?
I like that. Sure. Absolutely. Especially in intervertebral disc, because that's a place where you can put something, right? You can put a needle there and displace something and leave it there. And there's no good treatment for degenerated intervertebral discs. It's amazing all the progress that we've made as physicians and scientists, and how many people are walking around with painful degenerative discs and no options. So I like the way you're thinking for sure.
Awesome, thanks.
Any other questions?
All right, well, I think that is it, and we're right up on, our closing time, so I think it worked out perfectly. Thank you so much, Dr. Prologo. This was wonderful, great learning opportunity, and we really appreciate you taking the time out of your evening to, kind of hang out and discuss all these topics with us.
Thank you for the opportunity.
We really appreciate it.
Have a great night. Thank you.
Thanks everyone for joining us.